Let me introduce you to Maria. She's 22 and scared. A heavy weight seems to be pressing down on her chest, making every breath a struggle. A persistent dry cough racks her body. With each exhale comes a high-pitched whistling sound, a wheeze. Her breathing is shallow and rapid, a frantic attempt to get enough air. Her nurse takes a quick measurement with a small device called a peak flow meter. The number is low, dangerously low. This collection of symptoms points directly to one thing: asthma. Maria's story is not unique. Millions of people around the world live with this condition every single day. Asthma is a long-term chronic disease that affects the airways. The airways, the small tubes that carry air in and out of your lungs. In people with asthma, these airways are always a little bit inflamed and sensitive. They can swell up, they can fill with mucus, and the muscles around them can squeeze tight, bronchoconstriction. This narrowing is what makes breathing so difficult during an asthma attack or exacerbation. Understanding this fundamental process is the first step for any healthcare professional. It's not just a momentary cough or a bit of breathlessness. It's a chronic inflammatory condition that requires ongoing management and respect. Maria's fear is real because the sensation of not being able to get enough air is one of the most terrifying experiences a person can have. As her nurse, your role begins with recognizing the seriousness of her situation. You must see past the symptoms and understand the underlying disease process. Your immediate goal is to help Maria, relieve that tightness and quiet the wheezing. But the long-term goal is just as critical. It involves empowering her with knowledge and tools she needs to control her asthma, so she can live without the constant fear of another attack looming over her. This journey from acute distress to long-term control is the essence of asthma management. Maria's case is a perfect illustration of why nurses must be masters of this topic, from the basic science to patient education. Let's move on to the lungs and mechanisms. To truly help patients like Maria, we'll look deeper into the lungs, see what is happening on a microscopic level. The pathophysiology of asthma is a story of three key events inside the airways. First, there is inflammation. Think of it like a sunburn on the inside of the breathing tubes. The lining becomes red, swollen, irritated. This inflammation is always present even when they feel fine, making the airways hypersensitive to stimuli. This sets the stage for the second event, excess mucus production. The swollen lining produces thick mucus, sticky mucus, that can clog narrow passages. The body's overzealous attempt to protect itself makes it worse. The mucus acts like sludge in a pipe. Asthma cough can be wet, productive as the body tries to clear thick fluid. Often the cough is dry. Hacking. The third and most dramatic event is bronchoconstriction. Small bands of muscle wrap around the airways, normally relaxed, suddenly squeeze, tighten. Imagine squeezing a garden hose. Flow is restricted. Airway diameter shrinks dramatically. This causes the classic wheeze as air is forced through tiny openings. The triad, inflammation, mucus production, bronchoconstriction, creates the perfect storm, leading to chest tightness, breathlessness, coughing that brought Maria in. Treatments target each component. Some meds relax tightened muscles for quick relief. Others reduce the underlying inflammation long-term and prevent attacks. For the NCLEX, remember, asthma isn't just tight muscles. It's fundamentally inflammatory. A rescue inhaler alone isn't enough for long-term control. We must calm chronic inflammation to truly manage the disease. That point is important to keep in mind. A crucial part of managing asthma is finding what sparks an attack. We call these sparks triggers. They can vary dramatically from one person to the next. For Maria, it might be dust mites in her bedding or pollen in the spring air. For another patient, it could be going for a run on a cold day. Common allergens: pet dander, mold, cockroaches, irritants, tobacco smoke, strong perfumes, cleaning products, air pollution, traffic or wildfire smoke, respiratory infections, common cold, flu, exercise-induced bronchoconstriction, stress, anxiety, laughter, cold, dry air. As a nurse, help patients identify personal triggers through careful history taking that lets them develop avoidance strategies. This is a cornerstone of preventative care. When we suspect asthma, we need objective diagnostic data. Start with a peak expiratory flow (PF) meter, a simple handheld device. A low PEF reading like Maria's suggests airway obstruction. The gold standard, spirometry. Spirometry measures how much air and how fast. Key is FEV1. A reduced FEV1 is typical in asthma. Repeat spirometry after a bronchodilator like albuterol. Significant improvement in FEV1 supports asthma. Know the classic signs: wheezing, especially on exhalation. Persistent cough, often worse at night. Shortness of breath, chest tightness. In a severe attack, signs get alarming. The patient may be unable to speak in full sentences, only 1 or 2 words at a time. They may lean forward and use accessory neck and chest muscles. Skin may become pale or bluish, cyanosis, and oxygen saturation will drop. These are red flags for respiratory failure that demands immediate aggressive intervention, so be ready to act fast. When a patient like Maria is in distress, our immediate goal is simple and absolute: keep her safe. Restore adequate airflow and oxygenation quickly. Rapid assessment of her breathing is your first action. How fast is she breathing? Is she using accessory muscles? Can she speak? What is her oxygen saturation? Based on that, administer quick relief meds as prescribed. Most commonly a short-acting beta-2 agonist, albuterol. Continuously monitor response to treatment. Look for improved breathing, decrease in wheezing, rise in oxygen levels. Once crisis is averted, shift to long-term control. Goal: help the patient live a full, active life. Control daily symptoms, prevent future flare-ups, maintain normal lung function, maintain normal sleep, maintain ability to exercise. Nursing education is the most powerful tool. Create a personalized asthma action plan with the patient. A written, often color-coded plan shows what to do every day and what to do when symptoms worsen. Long-term nursing actions are multifaceted. Teach about specific triggers and avoidance strategies. Allergen-proof mattress covers. A smoke-free environment. Teach rescue versus controller medications. Emphasize taking preventer medicine every day, even when they feel well. Patients often stop controllers because they feel better. Remind them controllers control underlying inflammation. Teach self-monitoring with a peak flow meter. Record peak flow numbers daily. Detect drops in lung function before symptoms. Adjust medication per action plan. Potentially prevent a full-blown attack. This proactive approach empowers the patient. It turns them from passive recipient to active partner. Collaboration is the foundation of chronic disease management and a key nursing responsibility tested on the NCLEX. The pharmacological care of asthma is largely divided into 2 distinct armies of medications: the relievers, the controllers. It is absolutely essential to understand the difference. The quick relief or rescue medicines are for immediate symptom relief during an attack. The workhorse is the short-acting beta-2 agonist, SABI. Albuterol is the most common example. They relax tightened airway muscles. Bronchodilation opens airways within minutes. Think of them as firefighters rushing in. Essential for emergencies, but they don't treat the root cause. Long-term control or preventer medicines are the foundation of management, taken daily to control chronic inflammation and prevent attacks. The most effective controllers are inhaled corticosteroids, ICS, fluticasone, budesonide. They reduce swelling and mucus in the airways. Other controllers include long-acting beta-2 agonists, LABA, usually combined with an ICS in one inhaler. Oral leukotriene modifiers can help. Montelukast, NCLEX tip: controllers prevent, relievers rescue. Beyond meds, non-pharmacologic care is key. The most effective strategy is avoiding triggers like dust mites and secondhand smoke. Other measures like weight loss and breathing exercises also support control. Proper inhaler technique is a critical nursing skill and a frequent topic on the NCLEX. For a metered dose inhaler, shake it, breathe out fully, then create a tight seal. As you begin a slow deep breath, press the canister. Hold your breath for 5 to 10 seconds. For patients who struggle with coordination, a spacer is essential. It holds the medication, allowing the patient to breathe it in without perfect timing. Finally, always wait 1 minute between puffs, and after using an inhaled corticosteroid, rinse the mouth with water and spit to prevent oral thrush. To succeed on the NCLEX, boil down this information into a quick checklist. First, define asthma as chronic airway inflammation with bronchoconstriction. Second, know the signs of a severe attack: inability to speak, use of accessory muscles, low oxygen saturation. Third, remember key diagnostics: spirometry that improves after a bronchodilator. Fourth, clearly distinguish rescue meds like albuterol from controller meds like inhaled steroids. Fifth, master the steps for correct inhaler and spacer use, including rinsing after steroid use. Finally, always prioritize creating an action plan and educating on trigger avoidance. Armed with this knowledge, you can confidently care for patients like Maria and excel on your exam.